Namaste, everyone, and welcome. I'm your professor, and today we're diving into something really important, the pathology of the lower urinary tract. Trust me, this is a system you're going to see issues with all the time in your clinical practice, so pay close attention, Yar. Let's begin.
Okay, before we get into the heavy stuff, let's start with a simple question to get you all thinking. Your urinary system, it's constantly exposed to, well, urine, which is basically toxic waste, right? So what do you think is its first line of defense? What's protecting the body from all that? The answer, my dear students, is a truly amazing tissue called the urothelium. And listen, this isn't just any old lining. No. It's a highly specialized, multi-layered epithelium. We're talking 5 to 6 layers deep. Its whole job is to be this incredible barrier. You can think of it like a high-tech, waterproof raincoat for the inside of your urinary tract.
And here you can see it for yourself. Isn't that beautiful? Just look how organized those layers are. See the cells, all nice and uniform? And that top layer? Those are the famous umbrella cells that form the main barrier. This is what it's supposed to look like. It's a perfect design. And as you'll see, it's when this perfect barrier gets damaged that the trouble really starts.
Okay, so our first major topic, let's talk about what happens when things get blocked up. Obstruction. This is one of the most common problems you'll encounter with the urinary system, so this part is super important.
So what causes these blockages? Well, it's usually a mechanical issue. In men, the classic example, the #1 cause is an enlarged prostate. It just physically squeezes the urethra. For women, a common problem is something called a cystosol. That's when the bladder actually prolapses or sags down into the vagina. And then, of course, you have things that can affect anyone, like stones, tumors, or strictures, which are just narrowings of the tube.
So what happens when there's a blockage? The body's response is actually quite logical. Remember, the bladder is a muscle, right? So if it has to push urine out against a blocked pipe, what does it do? It works harder. It's exactly like you going to the gym and lifting weights. What happens to your biceps? They get bigger. The bladder muscle does the same thing. It undergoes hypertrophy. It bulks up.
And here, this is what that looks like. Pretty dramatic, isn't it? What you're seeing here is the inside of a bladder that has been fighting against an obstruction for a very long time. All those thick, crisscrossing bands, those are the muscle bundles that have bulked up. We have a special name for this pattern. It's called trabecation. And when you see this, it's a dead giveaway for chronic obstruction.
Okay, let's move on from the plumbing problems, the mechanical issues, and talk about infections. Our next big topic, inflammation of the bladder. The proper term, as you know, is cystitis, and this is another one you are going to see constantly in your practice. So, for your exams and for your clinical life, what do you absolutely need to remember about cystitis? 3 things. 1, who's the bad guy? It's usually bacteria from our own gut, with E. coli being the main culprit by far. 2, who's most at risk? Females, and it's a simple matter of anatomy. A shorter urethra just makes it an easier journey for the bacteria. And 3, what are the classic symptoms? Remember this triad: frequency, having to go all the time, lower abdominal pain, and dysuria, that horrible burning feeling during urination.
All right, everyone. Now we need to talk about the most serious topic of the day: cancer, neoplasia of the bladder. This is a big one, a major cause of suffering and death around the world. So understanding the basics here is not just for your exams, it's absolutely critical.
So let's get straight to the point. What is the single biggest risk factor for bladder cancer? Look at the chart. There is no question. It's cigarette smoking. The connection is unbelievably strong. We're talking about 50 to 80% of all cases in men. Think about what's happening. The carcinogens in the smoke get into your blood, your kidneys filter them out, and then where do they go? They collect in the urine and just sit inside the bladder for hours, just bathing that delicate urothelium in poison. It's a direct chemical attack.
Now, from a pathology perspective, this is really interesting. Bladder cancer isn't just one disease. It develops along 2 main pathways. The first is the papillary pathway. These tumors grow out into the bladder like little fingers or fronds. They tend to be lower grade, but the frustrating thing is they often recur. They keep coming back. The other path is the flat pathway. This leads to something called carcinoma in situ, or CIS. This one is very different. It spreads across the bladder lining like a thin sheet. It's always high grade, and it has a much higher risk of becoming dangerously invasive. And as you can see, they're even caused by different genetic mutations.
Here's a perfect example of that papillary pathway. See that? It's a large tumor growing right into the space of the bladder. Grossly, it can look a bit like a cauliflower. We call this an exophytic growth. It's literally taking up space inside the bladder.
Okay, so we've talked about papillary tumors, flat tumors, low grade, high grade, but listen carefully. There is one single thing that is more important than all of that when it comes to a patient's outcome. It is the critical turning point. Let's talk about what that is.
But first, just look at this histology slide. This is what high-grade cancer looks like under the microscope. The cells have gone completely crazy. They've lost all their organization, they're all different shapes and sizes. That's what we mean by pleomorphic. The nuclei are big and dark, we call that hyperchromatic. It is total architectural disarray. It's pure cellular chaos.
But even looking at this chaos, the most important question still isn't answered. What is it that makes one tumor so much more dangerous than another? What is the dividing line between a cancer we can probably manage and one that's about to become a killer? To answer that question, you first need to know the basic anatomy of the bladder wall. It's simple. On the very inside, you have the lining, our friend the urothelium. Right underneath that is a layer of connective tissue, the lamina propria. And then, the most important layer for this discussion, you have the deep, thick muscle wall, the muscularis propria. That's the muscle that does all the work.
And here it is. This is the key point of the entire lecture, students, so please listen. The absolute game changer is when the cancer invades into the muscularis propria. The moment those cancer cells breach that deep muscle layer, the whole story changes. The prognosis becomes so much worse. We call it muscle-invasive bladder cancer, and that's when it has the potential to spread to the rest of the body. Staging, which is all about depth of invasion, is everything. Okay, let's bring this all together. Let's summarize the most important clinical takeaways. This is the stuff you absolutely have to burn into your memory, not just for an exam, but for when you have real patients in front of you.
Number 1. And if you remember nothing else, remember this. Painless hematuria. That means blood in the urine, but with no pain. This is the most common way bladder cancer shows up. Any adult who comes to you with this symptom must, I repeat, must, be investigated for cancer until you can prove it's something else. It is a massive red flag that you can never, ever ignore.
So to recap the whole lecture, Message 1. Painless blood in the urine is bladder cancer until proven otherwise. Message 2. Cigarette smoking is the #1 enemy here. It's the biggest risk factor by a mile. Message 3. Prognosis all comes down to one thing, the depth of invasion. Has it hit the muscle? That's the critical question. And finally, Message 4. Putting it all together, it means that finding these cancers early, before they invade the muscle, is absolutely the key to saving lives.
So I'll leave you with one final question to think about. After everything we've talked about today, the huge link to smoking, that one critical warning sign, what is the most important conversation that you can now have because of this knowledge? Maybe it's with a future patient, or maybe it's with a family member or a friend starting today. Think about it. Thank you.
Hello again, my dear students, and welcome back. Today, we are continuing our journey into the pathology of the male genital system. We are going to cover some very, very important pathologies of the penis and the testis. Trust me, this stuff is super high yield for your exams and for your life as a doctor. Cello, let's get started. So let's start with a situation you will see in your OPD one day. A young man, maybe your own age, comes in with a lump in his testis, and he tells you, "Doctor, it doesn't even hurt." Now, why is this a red alert, a urological emergency? Keep this question in the back of your mind, because it's the whole point of what we're learning today. So, what's on the menu for today? First, we'll talk about the penis, inflammations, tumors, and a closer look at squamous cell carcinoma. Then, we move on to the testis, covering some developmental issues before getting to the main event, testicular tumors. We'll finish up with the classifications and the most important clinical points you must remember. Let's go. Okay, first up, let's tackle penile inflammations and tumors. We're going to follow a logical path here, starting from something relatively simple like warts and see how things can sometimes progress to something very, very serious. Look at this. This is condyloma acuminatum. Basically, it's a benign wart. And what causes it? Well, usually it's our old friend HPV, but the low-risk types, 6 and 11. On the left, you see the big picture, this branching finger-like structure. But the real money shot is on the right. Zoom in. You see those cells with that funny-looking, dark, crinkled nucleus and that white space around it? That, my friends, is a quiliocyte. This is the pathognomonic, the absolute telltale sign of HPV. You see this, you think HPV. Simple as that. Okay, so we've seen a benign condition. But what happens when things start to get nasty? That's where we get something called penile intraepithelial neoplasm, or PIN for short. Think of it like this. It's cancer, but it's playing by the rules. For now. All the bad-looking dysplastic cells are there, but they haven't invaded yet. They are respecting the boundary, that basement membrane. It's carcinoma in situ. And this is a classic example of PIN, what we call Bowen disease. This one is linked to the bad guys, the high-risk HPV, like type 16. Just look at this slide. Normally, cells should mature as they go from the bottom to the top, right? But here, it's chaos. From top to bottom, it's full of these ugly, dark, irregular cells. There's no discipline, no maturation, and the scary part? There's a 1 in 10 chance that this will break through that basement membrane and become a full-blown invasive cancer. So, what happens when that 1 in 10 chance becomes a reality? When those undisciplined cells finally break down the walls and invade? Well, that's when you get invasive squamous cell carcinoma. And this is what it looks like in a patient. An ugly, cauliflower-like growth. It's irregular, it's breaking down, it's ulcerating. And what causes this? 2 main culprits. Poor hygiene leading to constant irritation and inflammation, and of course, high-risk HPV. This is exactly why, clinically, circumcision is known to be protective. It just makes hygiene much easier. Now listen up, this is a Viva question for sure. The latest WHO classification. It's simple, really. It tells us that penile cancer isn't just one disease. It has 2 different roads it can take. One road is driven by HPV. The other road has nothing to do with HPV. It's more about that chronic inflammation we talked about. So you have HPV-associated and HPV-independent. Remember this.
Okay, enough about the penis for now. Let's move down to the testis. We'll start with something that goes wrong right from birth, a congenital issue, and then we'll look at some other problems.
This number, I want you to burn it into your brain 4 to 10 times. That is how much higher the risk of testicular cancer is if a testis doesn't descend properly, what we call cryptorchidism. This is not a small increase. It's a huge red flag, one of the biggest risk factors we know. And here's the why. Look at the picture on the left. That's a normal, healthy testis. See those nice, open tubules busy making sperm? Now look at the right. That's the undescended testis. It's a disaster zone. The tubules are scarred and shrunken. The germ cells, the ones that make sperm, are gone. So what are the consequences? 2 big ones. 1, infertility. And 2, that massive 4 to 10-fold increased risk of cancer.
Speaking of emergencies, here's another one. Testicular torsion. The spermatic cord literally twists like a rope, and snap, the blood supply is cut off. You can see the result here. It's dark, it's bleeding, it's dying, it's an infarct. There's a very, very small window, maybe 6 hours, to untwist it surgically. If you don't, that testis is lost forever. It is a true emergency. All right, now for the main topic of the day, the one you've all been waiting for, testicular tumors. Pay close attention, because everything we discuss now is super high yield for your exams, and more importantly, can save a young man's life. This chart makes it very, very simple. If you hear testicular tumor, what should pop into your head? 95% of the time, you should be thinking germ cell tumor. It's that easy. Almost all of them come from germ cells. The other little slice, that 5%, is other stuff. But the big story, the main character, is the germ cell tumor. Okay, so within that big 95% group, we have 2 main families. Think of them as 2 brothers. On one side, you have the seminomas. This is the well-behaved, predictable brother. They look uniform, they listen to treatment like radiation, and the outcome is usually very good. Then you have the other brother, the non-seminomas. This is the wild, chaotic one. They're more aggressive, they spread faster, and they're harder to control. Knowing which brother you're dealing with is absolutely crucial for the patient. So let's meet the family members properly now. We're going to look at a few examples, and you'll see just how different they can look, both with the naked eye and under the microscope. Here he is, the most common one of all, the seminoma. See how it looks? It's a big tumor, yeah. But when you slice it open, it's so neat. It's uniform, fleshy, gray-white. You don't see any messy bleeding or dead tissue. Its appearance matches its personality, well-behaved and predictable. And this is the microscope view, another Viva slide. Look at the cells. They are big, they all look the same, like clones. They have this fried egg appearance with clear cytoplasm and a nice central nucleus. But look closer. In between the sheets of tumor cells, you see those little dark dots? Those are lymphocytes. The body's immune system is trying to fight back, and that's a classic feature of seminoma.
Now look at this. This is the wild brother, embryonal carcinoma. Can you see the difference? It's the total opposite of the neat and tidy seminoma. This is a mess. It's badly defined. You can see areas of bleeding, areas of necrosis. It just looks angry and destructive. And that's exactly what it is, much more aggressive. And then you have this weird one, the teratoma. The name literally means monstrous tumor. Why? Because it's like the tumor tried to make a person but got everything mixed up. It's made of all sorts of different tissues. In this one slide, you can see glands, you can see muscle, and that big purple thing is cartilage. You could find teeth, hair, brain tissue, anything. It's a complete jumble. Okay, so we've seen the good, the bad, and the weird. But how does this help us in the clinic? What are the key points you need to take away for your patients? Let's summarize that now. We have some amazing detective tools to help us, and these are simple blood tests for tumor markers. You must know these. AFP, or alpha-fetoprotein, that screams yolk sac tumor. HCG, the pregnancy hormone, that points to choriocarcinoma. And LDH is a general marker that tells us how big the tumor load is. And here's a golden rule. Write this down. A pure seminoma will never, ever produce AFP. If AFP is high, it's not a pure seminoma, period. So let's end where we began. You know the pathology now, you know the science, but what about that young man with the painless lump? All this book knowledge is zero if he is too scared or too embarrassed to come and tell you about it. Testicular cancer, when caught early, is one of the most curable cancers there is. So I leave you with this question, not as a student, but as a future doctor. How are you going to be the kind of doctor that a young man trusts enough to talk about something like this? That is not in any textbook. That's the art of being a doctor. Think about that. Tell a thank you.
Good morning, my dear future doctors. Welcome back. Today, we are going to discuss a very, very high-yield topic, something that will be with you throughout your entire career. Yes, we are diving deep into the prostate gland. We'll look at its two most common and important conditions. So, let's get started, shall we?
Right, so here is our lecture plan for today. First, we'll map out the territory, the anatomy. Then we'll talk about the benign growth, BPH. After that, we'll get into the serious business of adenocarcinoma. We'll also see how we grade this cancer, touch upon the great PSA debate, and then the final showdown, BPH versus cancer, side by side. A very logical flow, you see.
Okay, first things first. We have to understand the geography of the prostate. You can think of the prostate like a small city with different neighborhoods or zones. And why is this important? Because where a disease starts is our first big clue about what it is. In pathology, my friends, location is everything.
Now, you will read about 4 zones, but for your exams and for your clinical life, I want you to burn just 2 into your memory. The first is the transition zone. This is the inner part, the part that is hugging the urethra. This is the home of benign growth, what we call BPH. And the second one, the peripheral zone. This is the outer, back portion of the gland. This is the bad neighborhood. This is where most of the cancers start. So when you do a rectal exam and feel a hard nodule, you are touching this peripheral zone, and alarm bells must be ringing in your head.
Chalo, now let's zoom in, right down to the microscopic level. What a beautiful picture of a normal prostate gland. Now look very, very closely. You see 2 layers of cells lining the gland, hai? There's an inner layer of tall secretory cells and an outer layer of flatter basal cells. This is what I call the 2-layer rule. Please, I'm telling you, remember this rule. If you see 2 layers, it's benign. If one is missing, well, that's a different story we are coming to.
Tiege, let's move on to our first major disease, benign prostatic hyperplasia, or BPH. This condition is incredibly common. In fact, it is so common in older men that we almost think of it as a normal part of aging. You will see it again and again and again.
Just look at this number. 90%. Can you believe it? By the time a man reaches 80 years of age, 9 out of 10 of them will have BPH if you look under the microscope. Now, not all of them will have symptoms, of course, but the changes in the tissue, they are there. It's almost unavoidable. So who is the main culprit? What is driving all this growth? It is this fellow right here, dihydrotestosterone, or DHT. You can think of it as a super testosterone. And inside the prostate, it acts like a powerful fertilizer, telling all the cells, both the glands and the stroma, to just grow, grow, and grow. This is why some of the best medicines for BPH work by blocking this DHT. Simple, no? And this is the result of all that growth. Look at this specimen. This is a prostate gland which is huge because of BPH. And can you see the urethra, the tube running through the middle?
It has been squeezed shut. It looks like a tiny little slit. Those growing nodules from the transition zone are pressing inwards. It's basically a plumbing problem, a simple mechanical blockage. And that plumbing problem leads directly to all of these symptoms. It just makes perfect sense. If the pipe is blocked, the patient has to go to the bathroom more often, especially at night. He has trouble starting the stream, and it's weak. And because the bladder doesn't empty properly, he's at risk for infections. You see, the pathology explains everything.
Okay, now we must change gears. We are leaving the benign world and entering the malignant one. We're talking about prostate adenocarcinoma. This is a very serious topic, Beta, because it's the most common cancer affecting men in many countries. But, as we'll find out, it's a cancer with a very, very wide range of behaviors.
When a surgeon takes out a prostate with cancer and we cut it open, this is what we might see. You see, it's not like the spongy BPH tissue. Cancer is often much more subtle. It feels firm, kind of gritty, and you can see this ill-defined gray-white area. To a pathologist's eye, this looks very suspicious. But under the microscope, then the difference is crystal clear. The cancer glands are smaller, they look more angry, and they are all crowded together, back to back with no space in between. They've completely lost their normal, polite architecture. It's a picture of chaos, cellular chaos. And here it is, the single most important feature for diagnosis, the money slide. Remember our two-layer rule, our golden rule? Well, in adenocarcinoma, that outer basal cell layer is gone, vanished, poof. Only a single layer of malignant cells is left behind. If you see this, you are looking at cancer. Full stop. This is the cornerstone of prostate pathology.
So once we say, yes, this is cancer, the very next question from the surgeon is, Doctor, how bad is it? Not all prostate cancers behave the same way. Some are lazy lions, some are aggressive tigers. To tell the difference, we pathologists use a very special grading system. This is absolutely critical for treatment decisions.
And this system is called the Gleason system. It is based purely on the architecture, how the glands look, and how they are arranged. Grade 1 glands look almost normal, very well behaved. Grade 5 is, well, it's total anarchy. No glands at all, just solid sheets of cancer cells running wild. And this picture shows the two extremes perfectly. On the left, a low-grade tumor. You can see the individual glands, nice and round, very uniform, very orderly. On the right, a high-grade tumor. Where are the glands? They're gone. The cells have forgotten how to make them. They're just growing in sheets. This one is the aggressive one. This is the tiger. Right, now let's take a small detour into the clinic. Let's talk about a blood test you have all heard of, PSA. It's used all over the world for screening, but let me tell you, it is one of the most debated, most controversial tests in all of medicine.
So why all the drama? Well, here's the thing. On the one hand, PSA is organ-specific. It's only made by the prostate, which is great. That's a pro. But, and this is a huge but, it is not cancer-specific. BPH can raise your PSA. A simple infection can raise your PSA. This means we get a lot of false alarms, which leads to anxiety and unnecessary biopsies. And sometimes we find these really slow, lazy cancers that would never have caused a problem, leading to overtreatment. It's a real dilemma.
Okay, my dear students, we now come to the most important part of this lecture, the grand summary, the final showdown. If you have been daydreaming, now is the time to wake up. Everything you need to know, all on one slide.
Let's go through this point by point. Ready? Zone of origin. BPH is central in the transition zone, so it causes urinary problems. Cancer is peripheral on the outside, so it's often silent. Histology, BPH has 2 cell layers preserved. Cancer has lost the basal layer, only 1 layer left. This is the key. Clinical effect, BPH blocks, cancer spreads. And finally, the most important point for your patients, BPH has 0 malignant potential. It does not, I repeat, does not turn into cancer. They are 2 totally separate diseases.
So when you have a patient with prostate cancer, I want you to remember this simple truth. Their future, their prognosis, depends on 2 things. First, the grade, that's the Gleason score we just talked about. And second, the stage, that's how far the cancer has spread. Everything else is secondary to these 2.
And I'll leave you with this one last question to think about. This is the great challenge for your generation of doctors. We are getting very good at finding these cancers, even tiny ones, but we know many of them are so slow-growing they would never actually harm the patient in his lifetime. So the big question today is not just how we treat, but who we treat. That is a very important thought to carry with you into the wards. Thank you very much.